Morning. Thank you so much for joining us today. I'm Avital Habusha. I'm the Vice President for Programs here at the New York State Health Foundation. During today's discussion, we'll be focusing on how to support hospitals and health systems to improve patient access to and use of shared clinical visit notes. We'll also be providing an overview of a recently opened request for proposals that the Foundation has released for expanding OpenNotes throughout New York State hospitals. We're joined by a group of health systems and patient partners who will provide us with an overview of their experiences, as well as our colleagues from the OpenNotes National Program Office. Before we get going, I want to just give you a few housekeeping items. We'll be recording this webinar, and a recap with a link to the recording and other materials will be circulated after within a few days. Video and audio are disabled for attendees, but we invite you to use the chat box throughout the event. We'll be monitoring those questions, and there'll be time for discussion throughout our panel. And for anyone who'd like to use the closed captioning option, there's a live captioning feature at the bottom of your screen, and you can feel free to turn that on. So just to give a bit of an overview, at the New York State Health Foundation, we've been committed to amplifying patient voices and making sure patients are at the center of the healthcare system through our empowering healthcare consumer priority area for many years. Our work promotes greater information transparency and engages patients as partners. Part of this approach has been ensuring that patients have the tools and the information to manage their own care, advocate for themselves, engage in shared decision-making, and make choices. And shared clinical notes have become a very important resource for patients and families to meet this goal. Our event today is coming at a pivotal moment. As you all know, as of April, under a provision of the 21st Century Cures Act, a federal law, which we'll hear more about in just a bit, healthcare providers are now required to give patients electronic access to most kinds of medical notes. And while many New York providers, including many of you, were already sharing notes before April, on the whole, this is a sea change for patients and clinicians alike. And we see it as an excellent opportunity to go beyond compliance and implement the requirement in a way that meets the needs of patients, families, caregivers, and clinicians, and to overcome barriers related to things like technology access, language access, to support equitable distribution of notes. We're excited to have a great discussion today about how health systems can seize this exceptional opportunity to build transparent communication and mutual trust among patients and health professionals. And we'll be highlighting lessons learned from organizations who were implementing OpenNotes prior to the federal mandate. And these panels are going to share with us best practices and strategies for engaging patients and making note sharing easier and more productive. So first, without further ado, I'd like to turn it over to Kate DeRoche, who's the Executive Director of OpenNotes, which is an international movement committed to spreading and studying the effects of transparent communication among patients, families, and clinicians based out of the Beth Israel Medical Center. And after Kate's presentation, I'll jump back on to share a bit more about our experience here at the Foundation supporting the expansion of OpenNotes, and I'll introduce our other panelists. So Kate, I'm going to turn it over to you to give us a bit of an overview of the new federal mandate and what OpenNotes has been working on.
Great, thanks Avital, and thanks for both organizing this event and for the support that the Foundation has given to the idea of spreading OpenNotes over the last, I think we're in our at least 6th year of this work. So thank you for that. And I am going to share my screen. I have a few slides to talk through that go over essentially the sort of a little bit about the history of OpenNotes, about the new federal law, and where things are going next. So as Avital mentioned, the 21st Century Cures Act, that's the act that eventually leads us to the information blocking rule. The Cures Act was signed into law. It was one of the last major pieces of legislation of the Obama administration. And the overarching goal there really was to advance biomedical innovation. But there is a piece in the law that directs the Department of Health and Human Services to improve interoperability and to leverage the power of EHRs to improve patient care and patients' access to their own information. Fast forward many years later, and we get to something called the USCDI, or the US Core Data for Interoperability. So this is essentially the information blocking rule that pertains to clinical notes. So in the Cures Act, there's a line in there that says patients should have access to all of the electronic information that is available in their health records. And several years worth of discussion about what the word all means led to this new core data set for interoperability. And it includes a lot of fields that were already had to be exchanged and some new ones. And for our purposes, the new ones that we have been focused on are the clinical notes. And there are 8 different kinds of clinical notes that need to be included in the data that has to be easily exchanged between providers and available to patients at no charge without delay. So you can see here, there's these 8 different kinds of notes, and this finally went into effect on April 5th of 2021. It was originally scheduled to roll out in November of 2020, but due to the COVID-19 pandemic, that date was pushed forward to April to give providers a little bit more time. So I want to just take a step back for a minute and acknowledge that patients have been able to access their records through patient portals for quite a few years. That was one of the early parts of meaningful use, that certified EHRs had to have a patient portal where patients could go on and use something called the view, transmit, and download function. That allowed patients to download their relevant information that they wanted. But it worked, and up until very recently continues to work the way the internet used to work. So if you go into the Wayback Machine, which is a real thing on the internet and is kind of fun to go down the rabbit hole of what the internet used to be like and how it's changed, this is a screenshot from the Sears catalog. And way back in the early days of the internet, if you wanted to order from the Sears catalog, you went on, you downloaded the PDF of the entire Sears catalog. You scrolled through it until you found the thing that you wanted, and then you went to the form and you filled in the item number, the catalog, the item description, page number, size, and then you added that to your basket. And that is the way that the view, transmit, and download button essentially worked. You got this giant lump of information, like a giant PDF, which had everything in your record. So not exactly useful, not as useful if you were trying to find out something specific. But now the internet has been modernized, and if I go on to Amazon and I want to find Beyonce's Lemonade, I would type in the search bar, Beyonce Lemonade. I might even only have to type in lemonade. And this is just an example of the code, the underlying code that you can see if you're interested. And what I get is exactly what I want. I don't have to scroll through every audio file that Amazon has on their server to find the one that I tell them which one I want. I just get exactly what I want through the search bar. That's the way the modern internet works. That's the way Uber works and the way you do your banking online. And that's what the information blocking rule and the 21st Century Cures Act are pulling healthcare into that modern internet era. So the records become, the notes and the reports become searchable in a way that they haven't been in the past. And this allows third-party apps to get involved. So the other piece of the information blocking rule that is going to be rolled out over the next few years, or the next year and a half, is the Open API, which will allow any patients to access their own health information through any third-party app of their choosing. Now, this is already happening with some organizations. For example, Apple. This is actually my health record from Partners Healthcare. And this is native already to the iPhone. So I could authenticate myself with my portal credentials and download all of this information onto my phone. So that's where we're moving to, in that sort of modern internet era with electronic health records. So what does this mean for OpenNotes, and how does OpenNotes sort of track with all of this movement around pushing healthcare, health information technology forward? So we'll take a step back for a minute and just say that OpenNotes really is when patients can easily read their visit notes, usually through a patient portal. OpenNotes, the organization, I'm the director of OpenNotes, and we are a philanthropically funded group of researchers and dissemination experts and patient advocates who are focused on spreading this idea that patients should have easy access to their visit notes. And you can see this is a quick note about some of our supporters. And unfortunately, New York State Health Foundation is not on here, which is an oversight on my part. So I want to just press home the idea that this is not a technology or an app. We are technology agnostic. We are EHR vendor agnostic. In our early days, we worked with the EHR vendors to get them to code this functionality into their patient portals so patients could see the app, could see their information, but we are not a technology. We're not selling an app. We don't have a server full of notes somewhere that we're mining. So given everything that's happening, the move towards the modern internet, the fact that notes are required to be shared, why should organizations such as yours, people who are on this call, encourage patients to read their notes? And I think there are really there are a lot of reasons, but there are really 5 that stand out to me. And I'm going to talk about each of them. I'm going to spend a minute on each of them. The first is the big amnesia, which I'll talk about in a minute. Second is improved understanding of and adherence to medications. Third is increased trust in providers. Fourth, improvements in safety. And fifth, we see some signals around how transparency can help improve equity. Hold on, okay. So to start off, our data and data from other organizations mirrors really what we've found, but that patients report that reading their notes is important for taking care of my health, remembering the care plan, having an active role, and understanding why a medication was prescribed, and taking medications as prescribed. So let's just talk about each of these for a second. When I mentioned before the big amnesia, that's something that I've heard described by patients, which is the phenomenon of being in the clinical visit, getting home, and not really remembering most of what you talked about. And that's very common. Patients, all of us, no matter how much education we have, we really remember about half of what we hear in a clinical visit. So 2/3 of patients saying, I read my note and it helped me remember my care plan. That's very helpful for this idea of the big amnesia. Using notes to improve understanding of and adherence to medications. We see that in several different measures. I want to draw your attention to this 14% taking medications as prescribed, that reading their notes helps them do this. We know what an enormous and costly problem, both in terms of financial, but also health and poor outcomes, adherence to medications is. If you could move it by 14%, that would be a pretty big change. Third, we get to the issue of improved safety. So this is clinician data, where clinicians say about 26% of clinicians said that there was a time when one of their patients found an error that the doctor considered clinically important. And when you ask patients, about 20% of them say they found a mistake in their notes. And what kinds of mistakes are patients finding? These are some serious mistakes. So Errors around diagnosis. And here's an example. The note said I was not BRCA1 when I am. So that's the genetic mutation that makes someone very susceptible to breast cancer. So you would really want that to be correct. Medical history, and this one kills me because it just seems like such a time suck for the patient. The diagnosis for the visit was incorrect. So this patient received a referral for physical therapy, but for the wrong body part. Mistakes around the physical exam, so the wrong BMI, couldn't be placed on a heart lung transplant list. And then medications, incorrect doses, or doses that are based on someone else's labs. And finally, just someone else's records are listed under mine, just completely the wrong patient. So these are significant errors that patients are able to find. Now, the other thing that we see is signals around increased trust. So almost all patients felt either the same or better about their doctor after reading their notes. And almost all of them reported the same or greater trust, teamwork, and goal alignment with their clinicians after reading just one note. And among clinicians, 50% of doctors believed that notes increased patient satisfaction and trust, and no doctors reported ordering more tests or referrals as a result of their patients being able to read their notes. And when we looked at this a little bit more closely and we stratified by race, so by Black, African American, Asian, and Hispanic Latino, or by education, so those with less than a high school education, all of those groups were significantly more likely to report that they felt better about their doctor and to report increased trust, teamwork, goal alignment, and activation. So we're seeing this signal among patients who might have good reason to be mistrustful of the healthcare system. And we see these differences hold even when patients don't say they're not actually reading the notes, but they know the notes are on offer. So something about just the offer of the note helps to create this relational benefit between patients and clinicians. Sorry, we're repeating that. So, and then finally, so that last slide included a little bit of information about equity. There's other work going on at other organizations that look at how notes can transmit bias to the next clinician. So in this study, these researchers at Johns Hopkins looked at the notes of patients who had been hospitalized with sickle cell disease for an acute sickle cell disease crisis. And of course, sickle cell disease is much more common among patients who are Black, who identify as Black or African American. And what they found when they went through these notes is many examples where there's language that could cast doubt on the patient report. So for example, patient reports 10 of 10 pain, but labs are fine. And if I understand it correctly, labs wouldn't necessarily show anything about a patient in a sickle cell pain crisis. They found language that perpetuates negative stereotypes, this sort of unflattering and perhaps unnecessary descriptions. So spent the day hanging outside McDonald's, last intake, so Swedish fish and chicken at 3 a.m. And finally, blaming the patient without any explanation for why the patient is not able to adhere to whatever the clinician wants them to be doing. So she took this study a bit further, and she showed two different vignettes. One was neutral, where a provider, where a survey respondent read, "He still has pain, rated 10-10. His girlfriend is by his side, but will need to go home soon," versus stigmatizing language. So patient is insisting that the pain is, quote, still a 10. Girlfriend is lying on the bed with her shoes on. So there's that unnecessary and sort of unflattering description, and requests a bus token, again, kind of a negative description of the girlfriend. And clinicians who read this stigmatizing version had more negative attitudes toward the patient, and they reported that they would use less aggressive pain management. So sort of shining a light on what's actually in the notes, clinicians knowing that perhaps a patient might read a note could help to reduce some of the kind of biased language that we're seeing. And then knowing that that can transmit bias to the next clinician may help to reduce stigma in some way. So this is very early. This is sort of very early work. So in summary, I'll just go back to the information blocking rule. So OpenNotes is here at the federal level. It is required. It is significantly broader than what we expected in terms of the types of information that have to be shared, so that there's a lot of opportunities to learn about how access to this information impacts patients and clinicians. Evidence from outpatient settings suggests that everything will be okay, that it'll be okay to share inpatient information with clinicians. There's not a lot of evidence to suggest that there's harm there. And then finally, I'll just stress that we won't get to the real benefits of transparency until patients and families are using the information in their records. So I want to leave you with this idea that if we just treat patient access to information as kind of a checkbox, yes, we do it, or no, we don't, and we don't try to really weave this transparent information into the care that we're providing, so that patients and families know that the information is there, they know how to get to it, and they know why they should be looking at it, and they know how to use it to make decisions about their care. That's where we want to get to, because that's where we'll see the benefits. Otherwise, we've created a lot of angst for clinicians and IT departments without getting to the real benefit of this change. And that is it for me. I don't know if we have a minute or two for questions, but I'm going to just turn it back over to Avital.
Great, thanks so much. I'm just taking a look at the chat to see if we have any questions. I don't see any questions now, so maybe what we'll do is we'll move on. I will give a bit of an overview in terms of the New York State Health Foundation experience working with the OpenNotes team and some of our history in supporting the program across the state. And then we'll have some time for questions throughout. So feel free to continue to use the chat if questions come up, and we'll definitely have some time to pause throughout the rest of our panel and then make sure we get to questions. Actually, before we get going, one question just did come in, Kate, maybe you can come back on to explain this, because I do think it's important for the rest of the presentations. Someone did ask about, is the portal itself required, or can information be provided by another means? And I think that's kind of probably a critical point for everyone.
Yeah. So if an organization is keeping patient information in an electronic format, then they have to provide that information to patients electronically. So that's one. There is an exception to the rule that's allowed, called the manner exception, and that's if you cannot provide the information to the patient in the manner that they request, but that doesn't exempt you from providing the information at all. It just means you can provide it in a different manner. But the intent is that if you keep information electronically, and that's even if it's a Word document, that information should be available to patients electronically.
Great, thank you. And then are there any best practices in terms of where the location of the note in the electronic health record? Just want that, maybe we can do that. And then there's a follow-up question around clinician best practices about telling clinicians if there's a mistake or something's wrong, but we might be able to get into a bit more of that later. Okay, so each electronic health record does it a little bit, each vendor does it a little bit differently in terms of where the notes are. Some make it quite easy. I've seen portals that
that have a sort of right on the side when you log in on the home page, you can click right on the notes there. Others, like MyChart, has several clicks that patients have to get to in order to get to the notes. In general, I would say the fewer clicks that a patient needs to take, the better. And if you are in a system where you're using, say you're using MyChart, which does have this navigation challenge, making it very obvious to patients through kind of wayfinding on the portal on how to get there.
Great. And then one follow-up question, and then we'll move on because they're all related. Does providing something from the EHR by email per a request from a patient, does that satisfy the requirement?
So I would say you should talk with your compliance officer about that, because I'm not a lawyer, so I don't want to be giving legal advice. There are sort of HIPAA issues involved around emailing as well. Although if a patient requests that you email them, if you say, we don't have a portal, but I can send you this file by email, then you don't have and the patient agrees, then you don't really have the HIPAA problem. But I would check with your compliance people about that.
Great, thank you. Thanks everyone for the questions, and we'll continue to answer questions throughout, so feel free to add to the chat. And some of these technical questions, you can also feel free to follow up with us after, and we can give some guidance on who we think is best to speak to if we don't have the answer. So I will now share my screen, and I want to give everyone a bit of a quick overview. There we go. A bit of an overview of our history at the New York State Health Foundation, working with OpenNotes and where we've been and where we're going. And then we'll jump into our panelists. So I'll be brief, but just to anchor everyone, the New York State Health Foundation has been supporting the OpenNotes initiative since around 2016. Many of our colleague funders, as you saw in Kate's presentation, have also been similarly supporting the initiative to try to expand OpenNotes across the country. We've obviously had a bit of a New York State focus. And so starting in 2016, as you can see here, we kicked off some of our work by piloting some projects with the Health and Hospitals Corporation and New York Presbyterians Accountable Care Organization in partnership with Weill Cornell and Columbia through an ACO pilot with Medicare patients and at Health and Hospitals. It was at 3 ambulatory care sites throughout the state. And that work taught us a lot about implementation in the hospital setting. It prompted us to move in 2017 to release a broader opportunity to engage hospitals from across the state. 8 hospitals ended up participating with us in about a 2-year initiative where they implemented OpenNotes in different settings, facilities throughout their hospitals with different patient populations. You'll hear a bit today from Dr. Bruckner, who was one of our participants in Rochester through that initiative. We were able to then parlay some of those lessons learned into a 2019 opportunity for federally qualified health centers and other non-hospital settings to implement OpenNotes with us. And we, really recognize there the critical importance of those community-based primary care organizations and their role in reaching patients throughout the ambulatory care settings. Those projects just wrapped up recently, some really great successes in those community-based settings, and you'll be hearing a bit more from the Institute for Family Health, who participated with us in that initiative with us just recently. And then finally, that brings us to today. In 2021, just a few weeks ago, many of you here today saw that we released a new RFP that we've called From Good to Great, really to engage even more hospitals to accelerate the adoption of OpenNotes, especially in light of the new federal rules, which you just heard about. We know that many hospitals are now implementing OpenNotes, and we really see this as an opportunity to go beyond compliance and, as Kate described, to really meaningfully engage patients in the OpenNotes process and help patients and providers use the notes in a meaningful way. We'll be discussing a bit more about the RFP opportunity and answer some questions there at the end of today's presentation, but just wanted to let people know that we now see ourselves moving in these next several years towards really this acceleration of spread through New York State. And so what have we learned? We've learned a lot through these initiatives. Successful implementation, best practices have emerged, many challenges as well. And we really think taking some of those lessons learned and challenges and how to address those barriers is something that hospitals now can do. We've seen many scalable strategies. OpenNotes, as you've heard, has a wealth of experience working with sites to scale different strategies that have worked in other settings. And so just wanted to highlight a few here today. We've really probably through our initiatives reached more than 1 million patients, but we now know that number can grow exponentially. And we've seen some interesting projects grow out of our work and our partnership with OpenNotes and New York State health systems. So for one, there's been some really interesting coordination across hospitals for regional implementation. Dr. Bruckner will share a bit more with us about how that happened in Rochester when 2 hospital systems came together to think about how to maximize their initiatives across the region. We've seen hospitals and community health centers implement patient navigator programs for non-English speakers, older adults, and others who might have trouble navigating the patient portal or accessing their note. So really to help patients actively use their note, to know where to find it, to answer any questions they may have. We've seen contracts with different vendors to help translate notes into other languages for non-English speakers. You'll hear more from the Institute for Family Health today, who's really done some really creative work around reaching people with limited English proficiency and working with them to create access to their notes in other languages. Similarly, outreach specialists have contacted patients to help them enroll in the portal so that they could see their notes. Some of our most recent work, for example, with Care for the Homeless, really showed that outreach specialists even work well with patients who might not be, might be experiencing homelessness and not have access to technology, using things like tablets in a site, and outreach specialists to create that linkage to the information in their record. We've seen really interesting provider training programs, and sites find ways to kind of engage clinicians themselves as champions of different models. And those clinician champions have really been able to help spread the OpenNotes outreach throughout their systems. And then finally, I think many of the hospitals who've really, and health systems and community health centers who've really been able to spread and scale have integrated a lot of what they've learned into their quality improvement initiatives on a day-to-day and into their patient experience program. So really integrating it into kind of the bread and butter of their operating and programming. So lots more to learn. We're excited that we have our panel here today to kind of give us some of the flavor of these ideas that I'm talking about. And then I think, one of the opportunities we have today is also to hear from different health systems who might be on this webinar and after the session about some creative ways that they've meaningfully engaged patients and integrated note sharing into their operations. So then just kind of continuing on that vein, just wanted to share a few ways to show how much the OpenNotes success has really been shared broadly across the sector. There's been lots of writing recently about how empowering patients can be facilitated through open note sharing. And we've seen many of our grantees really be able to spread their best practices in journals throughout the country. And I think that that's a really great way to allow other health systems to learn from each other. So I'm now going to turn it over actually to our panel. So before I get started, I just want to give some brief introductions. We're going to run through the panel in order that you see it in your agenda, but we're going to start with Stacy Whiteman, who is a longtime patient advocate at Beth Israel. And we're really excited to have her joining us today. She began her volunteer work as a patient advisor and volunteer at Beth Israel back in 2012. She's been a longtime advocate of OpenNotes, is really willing to share her experience with other patients, providers, family members. And I think we're really lucky to have that perspective from the patient to kick off our panel. I think that's, as we've said before, that's really where we want to ground our work, really through the eyes of the patient. And so excited to have Stacy here. She's going to tell you a little bit more about herself. And after Stacy's presentation, we'll pause for some questions. Our colleague Deb from OpenNotes will jump on to facilitate some of those questions. So feel free to keep them rolling in the chat. And we'll move on to our health system panel. We'll start with Dr. Bruckner, who's now at Roswell Park Comprehensive Cancer Center, the CMIO there. She's worked with us for many years on OpenNotes in the Rochester region, and she'll be giving some of her experience. We'll then turn it over to the Institute for Family Health and then Nandini Shroff, who is the grants administrator and the research committee administrator there, as well as her colleague, Dr. Ruth Lesniewski will join us, who's the clinical director for their My Charts, My Health program, will join us to talk a bit more about their program engaging patients who don't speak English and other patient engagement and strategies that they've used to be successful. And then finally, after the panel presentations, we'll have some time to give you a bit more information about the request for proposal opportunity and answer some of those questions. So without, let's see, I think I see Stacy on the screen. So I'm going to stop sharing my slides and she's going to tell us a bit more about her experience as a patient and advocate. So Stacy, thank you so much for joining us. And I turn it over to you.
Okay, great. Thanks, Avital. Thank you. I'm glad to be here. Imagine one day waking up and your life as you knew it was gone in a split second. The career that once defined who you were, gone. The skill set that made you successful, gone. The knowledge that was stored in your brain, database, gone. That happened to me, and so my nightmare began. I truly believe that if it were not for OpenNotes, I have no idea, in managing my medical care, I have no idea where I would be today. In July of 2013, I was diagnosed with progressive MS, and my life changed in the most unimaginable way. I will talk about my illness shortly, but before I tell you about my journey with OpenNotes and how they've been effective for me in managing my care, I first need to briefly explain how I got here. In July of 2013, I was diagnosed with progressive MS. And on that day, my life as I knew it changed in the most unimaginable ways in a split second. Prior to 2013, I was a very talented, high-functioning executive assistant. There wasn't anything I couldn't do, whether it be putting together fundraisers for Massachusetts leaders, or doing a worldwide officer group presentation, or managing applications, or whatever they needed me to do. I was one of the lucky ones. I had a great job. I loved getting up every day. I was good at it. I loved that my brain was full of so much knowledge and so much data that I always had answers at my fingertips. And I always say my brain could store hundreds and hundreds of phone numbers. There wasn't anything I couldn't do. I was always able to complete tasks from start to finish, participate in conversations, difficult or not, being an attentive mom to my 2 children, and who were young at the time. And I apologize that I'm reading some of this, but because of my MS, I don't want to lose my train of thought. I hope that's okay. My progressive MS came out of nowhere. I was losing my balance a lot, and then I fell down a flight of stairs and said, something's not right with me. My cognitive functioning decreased so rapidly that I could not make heads or tails of what was happening in my life. It was chaotic. It was like a bunch of different puzzle pieces now in my head, and I couldn't get through my days. The job that once defined me was gone. The skill set that made me so successful, gone. That was almost as worse as hearing about my diagnosis. At the onset of my illness, I was out of my mind, and my brain felt like a million different puzzle pieces, and I was fighting a losing battle. I was trying to fit all the pieces together, which became an impossible task for me. I was too afraid to read all the blogs because I didn't want to know how bad it could get. I was diagnosed in July, and by the middle of August, my cognitive functioning decreased so rapidly, I had no idea what I was doing anymore. Tasks became unattainable for me. I developed many physical and emotional issues, as well as balance, mobility issues, fatigue, which I did not realize could get so bad so quickly until I had a seizure on the highway and my daughter was in the car. My doctor told me because my fatigue was so bad, I lost all awareness, but I was conscious. My daughter snapped me out of it, and thank goodness we weren't hurt. I think that is what started me on my journey to find something to help me manage my care and my illness. I knew at that moment I would not survive unless I could manage my MS. My life was chaotic, and I remember going online saying, okay, there has to be a tool here that can help me get to my appointments on the right day or whatever it was. And I couldn't put all those pieces together. Life was chaotic. And I didn't want my kids to see me in my worst moments. I became someone I had no idea how to manage. I had no idea how to manage myself. So enter OpenNotes. Around December 2013, I was cognitively neuropsych tested. And from there, it came out that I was so stressed out that I could not manage my illness. And we all know that stress exasperates anything that you're going through, and it's hard to get through your day. I also need, my testing psychologist picked up on the fact that I was constantly worried about my future, my life. What did this mean for me? What did this mean for my kids? How will I be in the future? And from there, I was also, I'm sorry, I need to mention that I suffer from anxiety and depression as well. We all know that stress and anxiety can hinder any process of getting well or even managing your day. So from that meeting, she gave me the name of a BIDMC therapist, and I always say the rest is history. It was my second appointment in April of 2015. Was it 15 or 14? I think it was. And she said to me point blank, how are you going to feel about your OpenNotes and our therapy sessions going up on the patient gateway? And I said, I'm going to love it. And she said, why? And I said, because when I leave here, I have no idea what we talked about. I don't remember anything. The littlest distraction would just throw me off course for the entire day. So the nice thing about OpenNotes is I have them at my fingertips. I'm able to read them on a daily basis, whether it's for therapy or my medical care. And it was so incredibly effective that over time, my stress level was reduced and I was able to finally manage my illness. I felt like my life came back, not 100%, but I was finally able to manage my illness. OpenNotes allowed me to manage my care and understand what MS was. When I was first diagnosed with MS, I wanted no part of it. I didn't want to know what it meant. I didn't want to know how bad it got. I didn't start reading the blogs until my stress level went down. Then I could handle it. Then I could read the blogs. Then I could handle it. And I learned a lot during this process, and OpenNotes has been with me all along the way. Sorry. I also use my OpenNotes for any other medical issues that go along with having MS. Any test I have, any labs I have, I'm a big researcher. I would read my OpenNotes. I would go over to Google. I would research it. I'd have a better understanding of what was happening in my life so that I could formulate notes and send them to my doctors and write down my questions because I would always forget. And whenever I was on my OpenNotes, I always found something different, no matter what day it was. And because my illness is invisible, as I'm sure you're all looking at me saying, you know, she can't be sick, she's articulate, she's this, she's that. Well, it's an invisible illness, so it makes it challenging to get people to understand, especially my family members, to understand the challenges that I go through. And it wasn't until I was able to PDF my OpenNotes, send them to my family and say, if you really want to know what's going on with me, this is the best I can give you because I can't articulate it. I can't explain it. I don't know enough about it to be able to do that. I didn't want anybody to feel sorry for me. That wasn't who I was. I just wanted some understanding. And it was very, at the beginning, very frustrating to me that nobody really understood. But I have put the proper tools in place because I know what I'm up against when it comes to that. And OpenNotes isn't just a tool you can use to manage your care, but I also found it a great way for me to communicate with my doctors. I had to see a specialist, and I bring OpenNotes with me wherever I go. And he wasn't on the BIDMC gateway, so I brought my laptop. I opened up my OpenNotes and I showed him the records. And from there, he was able to have a better understanding of what he was trying to do to help me. And that is just a huge benefit for OpenNotes for me. OpenNotes has put balance back into my life. It has made my life less chaotic. I never want to go back to that place where my brain was a million different pieces. Going from a type A personality to somebody who was so weak and couldn't get through her days, and her kids had to go live with her dad, and then they went off to boarding school, and all the while I'm trying to hide my symptoms so nobody worries about me. I often ask myself, if it weren't for OpenNotes, where would I be today? Where would my illness have taken me? How would I have been able to manage it? How would I have been able to understand it? To be able to open up a line of communication with a hospital to help you manage your care is just so huge to anybody, especially for me. I need to understand everything. And I'd like to end with a story that was very profound to me. It was at an IPFCC conference. And after the conference, we were sitting at a round table. And these people couldn't envision what an open note was. So I pulled one up. And this woman next to me said to me, she practically had tears in her eyes. And she said, "Oh my gosh, I wished I had known about this. My husband had a lung transplant. And apparently it didn't take. And for weeks, he was dealing with this on his own because he didn't want to worry his wife. And it wasn't until the day before he was going in for another transplant or whatever it was he needed. She said, "Oh my God, if I had had this, he wouldn't have had to go through this alone. If I had read his medical records, I would be able to tell him what the plan of action was." And that always just stayed with me, because from that moment on, she said she was absolutely going to sign up for OpenNotes. So I hope I was able to explain the importance of OpenNotes in managing my care. It's an extension of who I was in my previous life. It's always with me. It's on my phone. I'm able to go to appointments on time. I'm able to find the locations of my appointments, and I'm able to read my results of any test, whether it be in my OpenNotes or not. And at the beginning of this, I had talked about stress and being able to manage your care, and everybody knows stress exacerbates the symptoms. So just as OpenNotes was rolling out and I was meeting my therapist, when I had started with MS in 2013, I had 4 lesions on my brain. They affect my mobility, my cognitive functioning, my balance. And when I started meeting my therapist, I had 11, and I have not had a new lesion since 2015. Coincidence? I don't think so. OpenNotes helped me manage my care and get my stress level, my depression, my anxiety back to a place where I could function again, and my kids wouldn't have to be worried about me. So, Deb, should I turn it over to you?
Hi, this is Deb Hockenheim from OpenNotes. Stacy, thank you so much for sharing your story. And you're such a wonderful advocate for OpenNotes, so we appreciate you speaking publicly about your experience. So I don't see any questions yet in the chat. I wanted to ask, when it comes to your therapy notes, not that I'm asking you to divulge any details, but as you know, because I know you presented with Steve from OpenNotes, who's our mental health notes expert, a number of times, there's often a lot of anxiety among providers around sharing mental health notes. And a lot of it is, the patients won't understand, they'll worry more, et cetera. So I wonder if you can talk a little bit more about that experience, particularly around the therapy notes.
Yeah, I'm a different kind of person in that I want to get better. I want to fix whatever the problem is, and I want to move forward. So what the OpenNotes in therapy allowed me to do was I could bring that home, get it up on my screen and read it until I understood every single thing. There was always an assessment. There was always a follow-up. There was always homework. And I needed that. It was as if my therapy sessions were just continuing to help me manage my care until one day I didn't have to go as often as I need to. I still go, and I still refer to them. I go all the way back to, oh, I remember this. I have to go back and find that. Or this is what she said. So I have to be able to tell my family, if you want to understand it, here's a copy of my OpenNote. Another piece I wanted to mention is my psychopharmacologist. He's not with BIDMC. He regulates my medicine. The beauty of OpenNotes is that if I'm having a problem or my anxiety level or depression seems like it's out of control, either my therapist or my medical doctor will say, you need to talk to your psychopharmacologist. So from that, I would PDF my OpenNotes. I would send it to him and I would say, I'm seeing you next week. We need to talk about this. And then I didn't have to think about it again until I walked into that office. So huge benefit.
And again, something else that providers worry about, not just with therapy, but any kind of providers, is that they might put in something that would upset the patients, or, you know, something that just would end up not going well in terms of the patient taking it in. So I'm just wondering if you've ever had any experience where something in a note has either upset you or been confusing or something unexpected that you kind of wished, well, I wish the doctor had talked to me about this. This wasn't actually something we talked about in the visit and it came up in the note. Anything that kind of happens unexpectedly.
Well, and as we all know, when we leave our doctor's office, we're always saying to ourselves, oh, shoot, I forgot to mention this or I forgot to mention that. I went for my MS checkup a few weeks ago and the doctor was running late and I was running late. So it was kind of a rushed meeting, but I had my OpenNotes with me and my questions. And I'm not an alarmist. So I don't know if I'm the wrong person to ask this question to, but because I want to fix myself and get better, I don't worry. Sure, there's certain things I see that I go, oh, what does this mean for me? And I'll email my doctor and say, do I need to be concerned? For example, this is a perfect example. I had an MRI, no new lesions, but there were other things in the MRI I didn't understand. So I would Google it and I would be like, what does this mean? And then I was able to email my doctor, my MS doctor, and say, do I need to be concerned about this? This was on my MRI results. That's all I want to know. If I don't need to be concerned, it's gone. But there are some people that I've asked. One of the conferences I did, this woman from London came up to me and said, Stacy, how do I get rid of the stigma of mental illness so that I can read my OpenNotes? And I said, that's a conversation for not, but I refer to it as therapy. And I said, and you have to be willing to accept what's written and try to figure out the direction that your life's going to go in. Now, I understand that people that are alarmist or that have psychological issues, they're not always going to get the information that I get because doctors are worried that if nobody's there to interpret that with them, who knows what direction they'll go into. I hope I answered your question.
Yes, thank you. Are there any other questions? I know we're moving on to the next speaker shortly.
Oh.
Okay, thank you, Stacy. And now Dr. Lauren Bruckner, so happy to have you here.
Hi, everyone. Can you hear me okay?
Yes.
All right. I'm just going to share my screen here. And Stacy, thank you so much for sharing. That was really powerful. And I hope what I'm going to say is going to dovetail with what we just heard, but from more provider and from the healthcare system standpoint. And I'll just say this is bringing me back in time because it's been a while since we've actually done. I've been thinking about those early OpenNotes days, and that's been 5 or 10 years ago. A lot has changed in just I think our appreciation of the value of sharing notes with patients. But what I'm about to share with you is at a time when that wasn't so obvious, and this was a really uncomfortable discussion that people were having when we would bring this information forward, when I would talk about this idea of sharing a doctor with other doctors of saying, hey, we're going to think about sharing your clinic notes with your patients, the response was generally not so positive. Even those with very open minds to it were sort of like, but why? And so just a lot has changed, I think, in our understanding of where there is value. So for starting off, I'm Lauren Bruckner. I am a physician. I practice in pediatric oncology, currently the CMIO at Roswell Park, but formerly was the medical director of patient engagement at URMC in Rochester. And back in 2017, when that RFP came out from the New York State Health Foundation, I found myself sitting next to my counterpart from Rochester Regional Health, which is our competing healthcare system. Between our two healthcare systems, we make up more than 80% of the healthcare in the Rochester region. And we decided, as we sat there listening to the presentations and talking about this concept of sharing notes, that wouldn't it be cool if we really did this as an entire Rochester community and really did it as a community-wide launch of OpenNotes. And so we, the Monroe County Medical Society, we added in for those, that other 15 to 20% that were not part of either of our healthcare systems, so that we could really include everybody. So this is the general timeline of what we did, and I'm not going to go into a tremendous amount of detail. Sorry, I'm just trying to, there we go. So we had the announcement that we were going to be on this journey towards what we called Open Notes with an Open Mind. That was back in 2017. We had both a voluntary opt-in phase where we just said, hey, this is something to try. Let's learn a little about it, get used to it, sort of a toe in the water, if you will, of trying OpenNotes. We then did a more formal primary care pilot where we did actually a study and looked at the results of when you automate the sharing of the notes. So rather than it being opt-in, this is now the sharing that's more of an opt-out, if you will. So the notes get shared automatically and you can choose on a one-by-one basis not to share a note, but the majority will be shared automatically. And I'll share with you some of those results. And then finally, what we did once we decided we were going to go implement OpenNotes throughout our entire enterprise and how we prepared for that. So first and foremost, establishing a governance structure. And I can't impress upon you how important this is to have a group that includes key stakeholders, particularly providers, meaning physicians and advanced practice providers, as part of the team that are helping to make the decisions around how you're going to share notes. And the reason I say that, so you see all these scope decisions that I have on this slide. Right now, a lot of those decisions have sort of been made for us because of the ONC regulations, these information blocking regulations. But there's still a lot of decisions that need to get made by each healthcare system. Each time it's how you are interpreting the ONC regulations, and there's still nuances about what's going to get shared and what are you going to do in cases of exceptions, et cetera. So there's a lot of decisions that need to get made around this, and having a governance structure and again, kind of empowering particularly the providers that feel like this is really impacting them and their workflows, I think is really important. So when we first started talking about OpenNotes, these were some of the reactions we got. Remember, a lot has changed since 2017, but there was really the sense of, as a doctor, these are my notes. What do you mean I'm sharing them with the patient? And I always broke this into 3 buckets of reactions. One was what I would call a paternalistic, but coming from a place of true concern, where there were providers who really felt like this was going to harm my patients. They were going to read things in these notes that were going to be confusing to them, or it was going to increase their anxiety. And out of that place, they felt this was a bad idea. The second bucket were the folks who went, my notes are a mess. I don't write good notes. If I'm going to have to start, and they're not meant for patients to read, if I'm going to have to start sharing these with patients, it's going to be a huge amount of work on my part to completely change the way I write my notes. That's not true. I'm just going to put that right up front. That is not true. That is not the intention. And there is not a lot you have to change as a provider when you're writing your notes, knowing that they're going to be shared. But that's a major concern when people first think about this. And then the last bucket is, oh my gosh, the number of phone calls I'm going to get, or the number of new messages that's going to create now, because I'm going to have to respond to all these questions. Even Stacy gave the example of on her MRI, even though it said that there was no additional new lesions, which is great. There were other things on that report. And so she messaged her doctor. So there was this concern about if everybody starts doing that with all of those little other things, it was going to overwhelm the healthcare system, the individual doctors, their offices. It was just going to be too much. All of that turned out not to be true. And I'm going to show you our data, but these were the concerns up front. So we decided to do it first, starting with this voluntary opt-in, what we called give it a try. And and I'm sorry, let me just say, so give it a try went first and went for about 4 or 5 months just by itself. And then we added in the nine providers in a primary care network group that were going to automatically share their notes. And so here's what the results of that looked like. And I just want to point out a couple of things here. So the voluntary opt-out phase, again, went for almost a year. And the automatic, the default note sharing was a much shorter period. And so we did our study right around here. And so it had been 8 months of the voluntary phase, only 4 months of the default note sharing phase. There were 230 providers that we had done all kinds of messaging and, had a communication strategy around trying to get folks to voluntarily share their notes. Yet it made up only 14% of the over 8,000 notes that got shared in that period of time. The 9 providers in the pilot where they were automatically being shared, in a half the amount of time, only 4 months versus the 8 months, had 86% of the notes that had been shared. So clearly the opt-in approach was not going to share enough notes to make it worthwhile. And really doing an automated, again, this default sharing is the key. We then did a number of surveys, first with the pilot group that had done the automatic sharing, and asked them the questions around the things that they had been most concerned about prior to being part of the pilot. Around, did you have to change the way that you wrote your notes or in a significant way? Did it mean you were spending more time in writing your notes? And the majority said no. Did you need more time to address patient questions outside of visits? The majority, no. Visits were not significantly longer. That was true. Everybody agreed. The visit times when they were talking to patients in their visits. As a matter of fact, we had the head of our cancer center actually, who was not initially in favor of this, came back to me and said, I have to say, I've really noticed a difference. My patients are better prepared when they come into the clinic visits now and are actually, there's more engagement. I'm able to have conversations with them in ways I wasn't before, and I think it's because they're reading their notes. So that was a major win for OpenNotes. And then lastly, were there lots of folks who said that finding what as providers would be felt to be more insignificant needs to change the note? Were there lots of requests about changing the note being made? And the answer was no. So those concerns on the provider side just didn't bear out in our study, and that is true. There's been many other studies besides ours that all showed that same thing, that really all those things that the providers were most concerned about just don't pan out in reality. We also did a more objective measure on the provider workload. And we looked at an 11-week period prior to going live with the OpenNotes pilot, and then 11 weeks after the OpenNotes pilot. And we looked at things like the length of the notes, the number of messages received via the patient portal, the amount of time the provider was needing to spend in their in-basket responding to messages, and the amount of time they spent in the notes activity. So these are all things we were able to get out of the electronic health record as objective data to say, was there any impact by going live with the OpenNotes pilot, by again, this was the default sharing of those clinic visit notes? And the answer was no appreciable impact on workload. We also asked patients during this pilot, what did you think about OpenNotes, about your ability to share, to have those notes shared with you? And what's amazing about this, and this was with, I'm just should give credit here, Get My Health Data is was also funded through a New York State Health Foundation as part of a different project, but helped us to do these patient survey. This survey was only open for 3 weeks. So it was a short time frame that it was just there. And it was, again, one of these kind of an opt-in. It was as you got notification that you had a note shared with you, you had the option to click and go take this survey about your OpenNotes experience. In that short 3-week period, we had over 1,000 patients complete the survey, 500 free text messages, which is just remarkable that almost half of them actually were so moved by the OpenNotes experience that they had lots of free texts and comments that they left, and it was overwhelmingly positive. I've never seen such a positive survey result. So clearly this resonated very strongly with patients and seemed as very much positive. As a matter of fact, the couple of negative things I'll just share with you, the few negative comments were all patients who were more concerned about the impact this would have on their poor doctor who was already overwhelmed with the amount of work that they had. So it was kind of reverse paternalism. So once we got that, the book pilot and the voluntary opt-in period behind us, and we made the decision, yes, we were going to go forward. It was around finalizing all those build decisions, developing and distributing training materials, and getting the word out that this was coming. And that word was out to just, everyone in the healthcare system that this would impact, which really was almost everyone, as well as to patients and our community overall. And so again, I can't stress the importance enough of having a really good communication strategy, because one of the things I found is I thought we were hammering people with how much stuff we had out there. And by people, I'm now talking about internally within the healthcare system itself. We had an intranet page that was dedicated to our OpenNotes. We had made videos with short little, I did a little video myself of the 5 things you need to know about OpenNotes as a provider, and tried to get down to the meat of it in a quick little video. We had free pens that had OpenNotes and reminder sticky notes that would remind them that this was coming, and all kinds of, I called it the horse and pony show, where we would go around and I presented at 30, 40 different faculty meetings and open houses and all kinds of things, all within the system, to try to make people aware this was coming. And yet at the 11th hour, we still had a lot of folks who said that they had no idea this was happening. I was like, what? So the importance of really hitting that messaging and multimodal messaging frequently, often, again and again. We also had patient marketing that we did, including also a little video that we made about the power of the patient portal that included around sharing notes as well, and gave out these kinds of brochures and had posters up and reminders on the portal itself that this was coming, all as ways of trying to raise awareness for our patients. And then because this was a community-wide launch, we actually did press releases as well and got advertising in the local media to get the word out. And so in the end, it all went smoothly. And I would say that the vast majority of the concerns that had been raised up front really didn't pan out. And that is the case that I think has been seen across all of the places where OpenNotes has been launched. The 3 highlights I would say about lessons learned here is, 1, the importance of upfront getting executive buy-in, because there are points like that when I told you about the 11th hour when folks, there was almost a mutiny. There was almost a period at the very last minute where the voice of some angry providers almost waylaid the entire project. But because we had gotten appropriate executive buy-in from the get-go, we were able to get through that period. So 1, executive buy-in, incredibly important. 2, involving providers in both a governance, creating of a governance, and about the implementation and the communication is critical. So having that kind of provider voice. And then 3, the communication strategy. It's so important that there's a good communication strategy that's, again, multimodal. So those, I would say, are the 3 biggest lessons learned that I can share. And with that, I'll turn it over to Deb for Q&A.
Thanks, Lauren. So if anyone has questions, please post them in the chat. While we're waiting, I'm wondering if you could touch on for just a minute how you've seen OpenNotes going at Roswell Park. I think oncology is another area where people sometimes get nervous about sharing notes.
Yes, and the notes so it's less the notes. I would say it's more the sharing of some of the pathology and the imaging, and so some of the more the result side of it, I think for the oncologist is more the issue. I'd say notes, where it's trickier for notes, is adolescents. There's a lot of issues around privacy and confidentiality when you're dealing with an adolescent, and mental health, as we heard earlier. I mean, I think, how do you put some of that information into a note? I can tell you what I do, but I mean, I think that there's more struggles when you're talking about things that have any type of a can be seen as a negative, because it's unfortunate that mental health is seen that way. But I do think that makes it more difficult. Or I'll even give the example in pediatrics in particular. Let's say you have concerns around the parenting. Let's say you have concerns around that there might be CPS type, concerns around potential abuse, or even just some negligence that might be going on. Commenting on that in a note that the parent is going to read is very tricky, but yet that's important information that you need to get into the documentation to remind yourself, if nothing else, to bring up. And so there's, I think, ways we are developing. There's some nuances to all of this, and I think a lot of that people are learning on how to. Oh, and I wanted to share one other thing. That whole idea of I have to completely change the way I write my note. My response to that, when providers would say that, is all you have to do is imagine that the patient or their parent or their proxy or somebody is looking over your shoulder as you're typing your note, or as you're dictating your note. That's all you really need to do. Your own common sense will take over the rest of it. The language you're using, you don't have to. The idea is not to write the note for the patient to read. It's you write your note keeping in mind the patient's going to be reading it, and that usually is all you need to do. And then the rest of it is common sense. But there are these nuances. There are these what I'd call more difficult situations where I think we're learning the best ways to navigate that. In our particular, back at URMC, what the approach we took for that is we actually do a double note for like adolescents, for example, at the point of the visit where we're asking the parent to leave the room and we're getting into what I call the sex, drugs, and rock and roll discussion with the patient, with the adolescent themselves. At that point, I open up a note and I tell them, this note is not going to be shared. This is just between you and I. This is the private information. The other stuff that we were talking about, your asthma care or your, diabetes management, that part is important that your parents have. And so, there's that ability to have sort of a sub note or a secondary note that is not shared, or on an individual basis, choosing not to share certain notes. Or even the patient may say, I don't want to have that note shared because I don't want my significant other to see that, or I don't want that information shared. So we're learning. And I think the key is involve the patient in some of these discussions. Like it's often, if I'm writing some information, I go back to Stacy's example. If I'm writing, or I think it was Kate that shared information about that could be misconstrued about like the way they're commenting about what they last ate or what they did. I show them the note as I'm writing it. And so I'll say, is this okay? Did I capture this correctly? Is this how you want this to be in the document, when it's, especially if it's something a little tricky? But everybody's got to figure that out. I mean, I think we're all, as providers, everybody's figuring that out now, is what's the best way to approach this that is not going to insult, because nobody means to insult, but that captures the information we need to capture in a way that is going to be helpful to everybody. Because again, the main, from my standpoint, the main idea for these notes is to share clinical knowledge with colleagues that need to know about it and for documentation for me to go back to and the patient to go back to. I think Stacy's point about, I don't remember everything I said in the last visit and I use my note to prompt me. Why shouldn't the patient be able to see that same prompt? I mean, it makes total sense.
Yes. Thank you, Dr. Bruckner. We're going to move on to the next speaker, but thank you very much for sharing your experience. It was a wonderful example at URMC and the partnership with Rochester Regional. We love talking about that experiment, I guess, the kind of community-wide implementation, which went really well. So thank you very much. And now Dr. Ruth Lesniewski and Nandini Shroff from the Institute for Family Health. Thank you very much.
Hi, everyone. Thank you for the previous panelist. I feel like there's so much overlap between our experiences, so it's really interesting to hear how other systems have fared. And sorry, do you guys see my screen?
Yes.
Great. Perfect. So my name is Nandini Shroff, and I helped oversee our OpenNotes implementation here at the Institute for Family Health. And I'll be co-presenting on our experience with this initiative with Dr. Ruth Lesniewski, who was our clinical champion around this project. And so just a little bit before I dive into OpenNotes implementation, I'll just give a brief overview of who we are. So the Institute for Family Health has 32 sites across New York City and the Mid-Hudson region. We provide primary care, mental health, and dental to over 115,000 patients annually. We actually have been on Epic since 2003. And really, the Institute was pretty excited about OpenNotes, especially when the New York Health State Foundation had come up with the RFP. We were super excited to apply for it. I think we strongly, our leadership really strongly believes that enabling patients to access their health care visit notes will increase their engagement in care and ultimately help improve health outcomes for them. So the Institute primarily serves the medically underserved populations. In terms of demographics, 29% and 38% of our patients identify as Black, African American, or Hispanic, Latino, respectively. 12% of our patient populations are 65 and older. 13% speak a language other than English. And in terms of insurance breakout, 48% have Medicaid, 13% are uninsured. And in terms of the English speaking or the non-English speaking population, we also have patient portal in Spanish that patients can sign up for. So 7% of our current active MyChart users are actually use our Spanish version of our patient portal. So in terms of our OpenNotes implementation, we actually, as an organization, we decided that we are basically going to share all of our notes. Doesn't matter if they go to primary care, behavioral health, dental care, nursing notes, all of the different social support services. So, and across all the different populations. So we did adolescent pediatric notes, as well as the regular adult notes too. And the first year for us was really essentially a planning year for us, where we did a lot of qualitative focus groups with patients. We also did a lot of staff trainings, and we completed our technical build in that very first year. And then the year two, we really focused on implementation and some of the post-implementation activities, including feedback, surveys, and sort of just looking at some of the quantitative data of how OpenNotes were faring with our staff and our patients. So in terms of some of the pre-implementation activities where we engaged our patients and staff, we did 3 focus groups across our New York City sites. So we had about 13 participants in all, and really, the findings from these focus groups were really just to inform our staff trainings and promotional efforts. And it was really interesting to talk to patients before we implemented OpenNotes about their feelings of what they thought about this rollout in the future. So no one really knew about OpenNotes, but once we sort of told them what the idea behind OpenNotes were, all of the patients were super excited about it. They all had a positive response. I mean, there were some aspects of OpenNotes I think participants were excited about, and I think this is stuff that Stacy had talked about before too, about how OpenNotes had helped her specifically. So participants spoke a lot about like increased transparency between them and the providers, sort of ensuring that the concerns discussed during the visit were accurately understood. They also spoke that having access to their notes would allow them to sort of reference what was discussed during their visits, like their care plan, prescription instructions, methods of coping, diets, and all of that, just so they don't have to rely on their memory alone. And they also felt like they would be way more informed about their own health, because then they can review what the note said in more detail during their own time and sort of better understand why certain things were discussed or suggested by their providers by sort of doing their own research after the fact. They also felt like it would actually ultimately lead to better communication between providers and patients. And they actually weren't super concerned about seeing the notes that they did not like or disagreed with. They felt like they would be comfortable approaching their providers to figure out why something was actually written or clarifying something that they did not sort of understand in their notes. So that didn't seem to be a big issue. Some of the issues that they did raise, though, was around possible provider documentation. They were concerned that providers would be using a lot of like medical jargon that might be hard for them to understand, or that providers might be more cautious about what they actually write, so that they might actually make the notes briefer. The other big concern that the patients really had was like the security of their health information in an online format, right? Like they were like, what if my healthcare information gets hacked, kind of a sort of concern. So not specifically to OpenNotes, but just, being in an online platform. And then we also, we sort of use the materials that are currently available on the OpenNotes website. We sort of adapted and developed presentation materials for staff, including PowerPoint presentations, sort of like a one-pager, a brief info sheet for reference for staff. And then some of our specific department leadership also sort of further adapted these materials for their own staff. So like, they did like OpenNotes for nursing, including information that's way more specific just for their nursing staff. We've presented, I think similar to what Lauren had said, we actually did a lot of presentations, and by me, I mean Dr. Ledzniewski did a lot of presentations across a lot of our regional meetings, site-specific meetings. I think altogether we presented at about 25 meetings with over 200 participants. And when Ruth was presenting to our providers and staff, a lot of the concerns that came up were, again, around increased workload, specifically having more messages or questions from patients regarding the verbiage in progress notes. This is very similar to what, again, what we've read in the literature and sort of the experience that Lauren spoke about, the initial concerns that their providers also had. And then some of the other considerations that we had to keep in mind as we sort of began implementing OpenNotes is, and especially because I think we implemented OpenNotes, or we were in the midst of implementing OpenNotes just as COVID-19 hit. So we were also like sort of dealing with the pandemic sort of impact. And then I think during that time, because a lot of healthcare systems sort of moved from in-person visits to telehealth, I think, we were at that point, very cognizant of like the digital divide that really exists, where really literature literature has shown that lower income families, the elderly, rural and semi-rural populations do have limited access to the internet, whether it's related to cost, availability of like smartphones, tablets, computers, or just internet providers, or even just knowledge of using some of these technologies or devices. And this is very similar to what our experience has been with our patients as well. So for example, only about half of our patient population actually have an active MyChart account. And of these, most of almost 90% of our users are between 18 to 65 years of age. And then we also see some of the disparities in MyChart users in terms of race, ethnicity, gender, and language over here. And then, as you guys are probably familiar, like I spoke about, I think during the pandemic, a lot of us sort of pivoted to providing health care through telehealth visits. And we've sort of noted disparities even in terms of people who utilize office versus tele-audio or tele-video visits for healthcare. So like at this point, I think most of our primary care visits are actually now happening in person. We've noticed that people who tended to be older, had Medicaid, or identified as Hispanic, or resided in sort of rural areas, they all had higher telephone visits compared to televideo visits. So just keeping these sort of technological stuff was really helpful in terms of identifying who might be actually able to access OpenNotes and which populations were being potentially being excluded. Another big factor that we sort of recognized was around health literacy, and again, being super aware of the impact of COVID-19, which had on our workflows and the ability of how we engage patients. We did actually leverage the implementation of OpenNotes to really review our note writing templates that we have and other sort of EHR features to ensure that they were patient friendly. We also use this opportunity to sort of boost our patient portal enrollment so that more people can access their notes online. And then during the peak of COVID-19, we also really intensified our efforts to help patients, get online. Our outreach teams really helped patients create email addresses, taught them how to access the patient portal, how to navigate that. So there was a lot of effort being made around that, since that was one of the key ways of getting people access, especially during COVID. And then this is sort of a brief workflow around how we were making OpenNotes available for non-English speaking populations. So really, when patients view their notes in the patient portal, we've basically put in a message asking them to submit a support ticket for notes translation. So on the back end, the message is actually routed to our case management pool, who then picks up the message, gets the notes translated from our translation vendor. And then the more, the ones in yellow is the more specific workflow around what the case management team does from the time that they receive the message through the patient portal. So the case manager will actually convert the note from PDF to Word, upload it to the vendor portal. And once the note is translated, they'll send it to the patient via MyChart and upload the note to the patient's chart in Epic as well. And so far, to be honest, no one has actually used it. So I'll talk a little bit more about why that might be. So I'll come back to that. And then in terms of implementation, we went live on in September 2020. We also employed an opt-out model, so that by default, actually all notes were accessible to patients unless the provider consciously made an effort to uncheck the share notes field. In actually April of this year, we implemented a hard stop for clinicians who chose not to share a particular visit note that actually required them to provide a reason for not sharing their note. I mean, this sort of coincided with, when the federal regulations went into effect as well, to make sure that we were actually sharing all of our notes unless there was a very specific reason for providers to not share a note. And then the two screenshots over here really show what the patients see on their end. So this is these two on the bottom show exactly what the patients see on their end once they open our patient portal. And this is sort of the notes section for our providers. And you'll see that the share with patient is automatically highlighted, and then they can uncheck that box if they don't actually want to share that specific note with a patient. And then prior to the go live date, again, similar to what UFR did, we also worked with our in-house communications team to sort of adapt and create patient promotional materials to raise awareness of OpenNotes and its availability through our patient portal. We created a digital slide to display in the waiting rooms, which is the screenshot that you see over here. And we had an FAQ sort of sheet for patients. We also included a message about OpenNotes and a link to the website in all of our after visit summaries and on our organizational website. And sorry, I'm just going to pause my video for a second. As you can see, my son's head might be popping out from behind. Hold on a sec. And then, so prior to the hard stop, the percent of notes shared with patients used to be about 80%. However, since the hard stop actually went into effect, that percent has increased to nearly 100%. And these are the notes that are deemed to be shareable. And it's really interesting to observe that only about 10 to 13% of the patients actually read these notes at any given month, actually. We are not sure if patients don't realize that they're now available, in which case we really still need to figure out, like, improve our awareness activities, or if patients just, you know, they might not actually want to view them. And then, like I mentioned, we do have a workflow in place to translate notes for non-English speaking patients, but so far patients have not really taken advantage of that availability. Again, we're not sure if it's a matter of us like having to improve our awareness of that feature or that service, or that there's just a limited need for it. A lot of the patients, the focus group participants actually did mention that they would just use Google Translate or other similar services if they did need the notes translated in another language. So these are some of the questions that we do hope that we are asking in our patient survey to sort of get an insight on. And that's one of the last post-evaluation activities that's still pending. And actually, I just got confirmation from my PMT team that that survey has been sent out this morning. So we're pretty excited to see what the results of that feedback survey will be like. And then this is OpenNotes by department. As I mentioned, we basically shared all of our notes regardless of which department it's going to be in. And apologies, this data is a little bit outdated since the number of shared notes is almost 100% across all the different departments. I think this graph is actually really useful to sort of compare the viewed rates by patients, and you'll see that it's very different. Primary care notes are the most viewed by patients, followed by mental health notes, and then the case, care management, and dental notes are pretty minimally viewed by patients. And then we also did some post-implementation evaluation of both providers and of our support staff. I'll quickly go through sort of our evaluation from our provider perspective. So we had about a 24% response rate for our provider survey with 95 respondents. 93% of the providers were aware of OpenNotes before the survey, before they took the survey. So it sort of indicated that a lot of the trainings and presentations worked. I mean, there were still a handful of providers who weren't aware, so we might have missed those, but overall, we felt like that's not, it wasn't too bad. 48% strongly agreed that making visit notes available is a good idea. While 55% of the providers stated that they have changed how they write their notes. 17% strongly agreed that patients who read their visit notes were better prepared, while 49% of the providers actually said their patients never brought up anything about a note they had written. Some of the benefits mentioned by providers included, just more transparency and encourages clinician accountability. Some of the challenges that providers face or recognize is that it might actually potentially cause harm for some patients, and this is particularly from our mental health providers, where it might increase patient paranoia or anxiousness that might lead to less openness with their healthcare mental health providers. It also sort of required more in-depth documentation, and they felt like they've experienced an increase in messages and phone calls. And then in terms of the support staff feedback, and these are nurses, our front desk staff, those are the people who got sort of the support staff survey. We had a slightly better response rate, is at 28%, but our N was 47. And then 83% of our support staff were aware of OpenNotes before the survey. 60% strongly agreed or agreed that making the visit notes available was a good idea. 62% of the patients never asked about OpenNotes in general. 62% said patients never really asked about OpenNotes. And 66% said they never received complaints from patients about what was written in their visit notes. However, when they did receive complaints, they were usually regarding misinformation, not really understanding information in the chart, or not liking what was written, or believe that there was a misdiagnosis by the provider. Usually when these kind of things came up, they would just refer the patient back to the provider. And then if support staff was unable to answer any sort of general questions, they did refer their patients to their providers or ask for assistance from other coworkers or manager. And then this is a graph that really shows the data for the reasons cited by providers when the hard stop popped up and they had to put in a reason about why they weren't sharing the note. And the number one reason for not sharing a note was that they felt like it might actually cause patients harm. And then followed by other reasons, such as the note was really just supervisory or administrative. So didn't really need to. Recent you'll see was that it was by patient request. I think that was actually my last slide. Deb, if you wanted to take over from here.
Yeah, so we did have a question about the translation of the patient notes, and Ruth did answer briefly in the chat, but if you wanted to expand on it, they asked if it was an Epic feature, and Ruth said that it's not, but if you want to talk briefly about how you came to figure out what to do with translation.
Yeah, so it's, like Ruth probably mentioned, it is not an Epic feature. That's why we have like this weird workaround where we basically in the patient portal put in a message saying, hey, if you do want this translated, contact a specific sort of subgroup when they put in the messages. I think you can select whether it's like a technical question or, and so this is for translation specific. And so they would choose that and it directly gets rerouted to the pool. So really, I think we sort of utilized the features that are available, not necessarily for translation purposes, but like what's there to sort of create a workflow that would sort of tie into like being able to get the notes translated for patients. So we really worked. So we had that technical build, and then we worked with like another vendor to make sure that we can get notes translated. So we changed our contract to add that translation piece with our vendor.
Great. Before we move on, Dr. Lesniewski, I didn't know if there was anything you wanted to touch on that came up or that hadn't come up during the presentation that you wanted to add.
Well, I think Nandini did a great job of summarizing our experience. A lot of people ask about complaints from patients, and what I'd just like to emphasize that there have been very few complaints from patients, and most of the complaints or concerns we've had have not really technically been about notes, but about other features which we'd already been releasing for many years, like test results or diagnoses. So I think it's great that we have this feature now, that we have more transparency, and our experience really replicated what we had read about in the literature regarding OpenNotes, where providers were really worried about it, that it would increase workload, and it didn't have much impact on our workload at all. I think you're muted.
Yeah, thank you. If either you or Dr. Bruckner wanted to touch on this, a question that just came up was, how does a patient ask to change a note? So if they saw something in a note that they thought was wrong or disagreed with, if there's a process in place.
That's happened in our organization, and I think the process is always initiated through a message on the portal. So I'm not aware of any other way a patient could initiate that process. I mean, maybe they could call the health center, but in my experience, it always starts with a message on the portal.
Dr. Bruckner, is it the same in your experience as well? Oh, she might have stepped away. Kate, I don't know if you want to add anything to that question about what you've seen, because I know this person has now asked the question a couple times, so I want to make sure we fully answer. Anything you've seen that systems do when patients see an error or want to request a change?
So it is something that organizations need to be ready for. So each organization should already have a process for what happens if a patient reports that there's a mistake in the note. It's a hard question to answer, because it's a hard question to give a general answer to, because the changes could be an actual mistake. It could be something that a patient didn't realize you were going to write in a note that they don't want to have in there. There may be ways that places deal with this using addendums to the note. So it really depends on what each individual organization's process already is and how they decide for each complaint. But place or healthcare organizations should already have a process in place. One thing one best practice that we have seen is organizations making it more transparent to patients about how to report a problem, because that's something that's not always very clear. And sometimes patients will write to the clinician and ask for a change. The clinician really isn't the person who can decide whether something can get changed or there's an addendum, and it has to go through a more formal process.
Thank you, Dr. Lefnewski. Oh, sorry, were you going to
Sorry.
add?
Yeah, I just wanted to respond to that last part. In my organization, clinicians can addend or change a note. So I actually think that if the problem is with the clinician's note, the clinician is the right person to deal with it.
And that's a perfect example of how the processes are just so different at all organizations. And we've heard stories of patients having to really take something right up the chain through to the leadership to get something changed in their record. So it's highly variable.
Can I comment on that one?
Sure.
So I know that we had to go through a whole process for that, because there are lots of ones, I agree with you, Ruth, where it's totally on me as the provider. I made a mistake. I acknowledge that yep, you caught me, that's a mistake. Thank you for catching it. And I should make the correction. Easy. Like that one should be a no-brainer. The problem is when I've pulled something into my note that somebody else actually wrote, or it's a medication that I didn't prescribe, somebody else prescribed, and the patient sees it in my note and says, I want you to change that. And the provider says, I'm not comfortable changing that. I have nothing to do with that part of it. Where does that then go? And so we had to come up with a process for handling, and there's a lot of those. There's a lot more of those than you would realize. And that's, I think, where it gets a little tricky, but still yet very, very important that the patient have that ability and that right to make the changes if they if there's something wrong in there or they feel it's not correct, it's not appropriate. And then there's the third group where the patient says, I don't think that's accurate. And the provider insists, yes, it is. This is what was discussed, or this is the diagnosis, and those ones can get tricky. And there's, again, we've created sort of a group to handle that and adjudicate if there's a disagreement.
Thank you everyone for your responses. Thank you, Dr. Lesniewski and Nandini, for your wonderful presentation. And we're going to turn it over now back to Avital to move towards wrapping things up and talking a little bit about the RFP.
Great, thanks so much. So I think what we'll do now is we have a bit of time left to talk a little bit more about the RFP opportunity. And I really want to thank our speakers for providing us with so much experience and animating kind of the OpenNotes process. So that leads us into this new opportunity that we're offering at the foundation. I'm going to share some slides, and then Kate and Deb and I are going to stay on the line to answer some questions about the opportunity and next steps. And we're of course available after the event as well. Let's see. Okay. So just wanted to give a bit of an overview. Most of you, and we'll share in the chat the link to the current RFP, what we're calling From Good to Great, Improving Access to and Use of Patient Visit Notes. This is an RFP that is due on December 6, 2021, so several more weeks of it open. It's pretty brief and straightforward, so we hope that it shouldn't be too big of a lift to apply. It's open to any hospital facility in New York State that is implementing and sharing OpenNotes in compliance with the new federal rules. And we're really looking for groups that are looking to go beyond compliance to meaningfully engage patients in innovative ways, implement some of these patient engagement and clinician engagement strategies that we've learned more about today. We know that hospitals across the state are in various places in terms of their implementation. Some have been doing it for a long time, others are just getting started and it's new territory. And we are the RFP itself is open to facilities that are both in the initial stages of implementing OpenNotes and those that are also seeking to optimize maybe their earlier implementation to make notes work well for clinicians and for patients. And we encourage those groups to apply, and happy to answer any questions in terms of where you fall on that spectrum. We'll be offering $30,000 awards per hospital facility and an opportunity to participate in a 12-month technical assistance and learning network headed up by OpenNotes, our colleagues here today, and other experts from the field. We're hoping to select between 25 and 30 hospital sites. And just a little more detail, the $30,000 grants can supplement costs associated with sharing notes. So that's a whole range of things like staff support, training and education, some of the marketing things that we saw, elements around EHR configuration or other kind of patient-facing tools. And there's some flexibility there, but happy to answer any questions. And hospitals will ask to engage, we will ask hospitals to engage project teams of 3 to 4 members. We really encourage a patient representative on those teams or a patient advisor if possible. And those 3 to 4 members can come from a variety of settings in the hospital, whether it's the IT department or the patient experience department. And the most competitive proposals will serve a marginalized population. They'll show initial compliance with the 21st Century Cures Act and its regulations, and will demonstrate some creative strategies to engage patients. So, and then I'm just going to turn it over a bit to Kate and Deb to give us a little bit more detail on the technical assistance and learning network aspect of the program. I've got up here on the screen some of the items that this 12-month program will address. It will allow some shared learning and also some real technical learning around specific issues. So I'll turn it over to you, Deb and Kate, for a minute.
Thanks. So Deb is the Deb will be the your sort of main point of contact for the technical assistance and learning network. And she and I have done several of these together over the last few years. And I'll note that our very first sort of big OpenNotes win happened in one of these kinds of groups, where a group of organizations in the Pacific Northwest got together, they learned from each other, and they all implemented together. And it was very powerful experience. What we will do is facilitate these meetings. We will line up speakers. So we'll do sort of a mix of what does the research say and what do people who are on the ground doing this, how are they making this work? So it'll be a mix of things, but we'll also be looking to the group members to let us know what they want to talk about. So we'll be kind of regularly soliciting topics from you all and hoping that as the group goes along, that it'll be less of us and the presenters and more of the groups more of the organizations talking to each other and possibly, bringing a problem they want to work on or bringing a solution to share with the group.
And what makes this, as you've heard now a few times, we've been through a few rounds of working with cohorts in New York State. What makes this one different and very exciting is that all organizations have had some kind of exposure to sharing notes at this point. So there's still going to be some conversation around, helping providers get over some of their reluctance around certain areas, et cetera. But there will be some kind of shared experience to some degree with sharing notes and doing open notes. So it'll be exciting to kind of then help elevate those implementations to a level where it really is effective and is helping in patient care.
Great. Thanks, Deb and Kate. And so I think we'll move on to some questions. We're going to monitor the chat. We have up on the screen here some of the email address for programmatic questions related to the opportunity, and then technical questions related to the New York State Health Foundation's online portal. So that's also listed in the RFP opportunity. We may not be able to answer all of the kind of specific questions for your specific hospital facility today, but happy to follow up on those questions, and feel free to put them through that OpenNotes RFP email if we don't have the opportunity to answer that today.
So Avital, there is a question in the chat. Can an award be more than $30,000 even if already implemented? Promoting open notes effectively is an expensive proposition.
Yes, and we 100% recognize the level of cost that goes into open notes, and don't expect that $30,000 would be sufficient to implement, but we are capping the awards at $30,000 so that we can reach as broadly as possible across New York State. We really want to be able, especially given the moment in time that we're in, we really want to be able to make as many awards as possible. And so unfortunately, we can't go above that amount, but we do recognize how expensive the proposition is. I'm just looking in the chat to see if there are any other questions. And if anyone has